Okay. Namaste. Good evening, friends. I am Dr. Shubham Purkayastha, consultant gastroenterologist of Apollo Excel Care Hospitals. Now, today I am going to discuss on a very important topic, which is cirrhosis of the liver. Now, the liver is a very important organ of the human body, and it performs a wide variety of functions, which include functions like synthesis of proteins to drug detoxification to synthesis of biles. So it performs very important functions of the body on a day-to-day basis. Now, so what is cirrhosis of the liver? Now, cirrhosis represents a common end stage of a variety of chronic liver diseases. So whenever there is a chronic liver disease which is causing inflammation or injury to the liver on for a long time, then the ultimate end result is cirrhosis. And what happens in cirrhosis? In cirrhosis, there is loss of normal functional tissue of the liver, and as a result of which the function of the liver is reduced. So next comes the point is, what are the causes of cirrhosis? So as I have already mentioned, a lot of chronic liver diseases can cause cirrhosis. So these includes chronic viral infections like hepatitis B, hepatitis C, as well as hepatitis D. Then your alcohol abuse, which can lead to cirrhosis. Then nowadays a very common problem which is encountered frequently is non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. Cirrhosis can also be the result of autoimmune diseases like autoimmune hepatitis, primary biliary cholangitis, or primary sclerosing cholangitis, as well as it can be seen in some metabolic or inborn errors of metabolism like Wilson's disease, alpha-1 antitrypsin deficiency, glycogen storage disorders, galactosemia, as well as hemochromatosis, which is a condition associated with iron overload. So what are the stages of cirrhosis, or what is the natural history of cirrhosis? So once cirrhosis develops clinically, we classify cirrhosis into two stages: compensated cirrhosis and decompensated cirrhosis. So compensated cirrhosis is the first stage of cirrhosis, where although there is presence of cirrhosis, the liver is able to maintain the liver function, and patients usually do not have much symptoms or signs of liver disease at this point. Now, this compensated cirrhosis, it represents a watershed area, because once the liver disease, it progresses from compensated cirrhosis to the decompensated stage, then there is marked reduction in survival of the patient, as well as there is worse prognosis. So for example, if a patient is having compensated cirrhosis, then the average survival is approximately 10 to 12 years. But once the compensated cirrhosis converts into decompensated cirrhosis, then the survival reduces to less than 2 years, that is until death or liver transplantation. So the transition from compensated to decompensated cirrhosis is a very important watershed area when the natural history of cirrhosis is considered. So what are the factors which can lead to decompensation? It is actually the ongoing liver injury that leads to decompensation. So what we can do to prevent the cirrhosis from going from compensated stage to decompensated stage, or what we can do for preventing the development of cirrhosis in patients who are having chronic liver disease. So first, and one of the most important step is abstinence from alcohol. See, alcohol is one of the common causes of cirrhosis, and initially, if we see the spectrum of alcohol associated liver disorders, then the patient may have fatty liver, or the patient may have alcoholic hepatitis, and at last alcoholic cirrhosis. So with abstinence from alcohol, the ongoing injury to the liver is decreased, and as such, studies have shown that the progression from compensated to decompensated cirrhosis is reduced. Also in patients, if we consider non-alcoholic fatty liver disease or NASH, There, the main treatment that we suggest for patients for undergoing to prevent the progression of cirrhosis is weight loss. If a patient with non-alcoholic fatty liver disease can undergo 7 to 10% of weight loss, then it is seen, studies have shown that there is significant reduction in the progression of the disease, as well as there is improvement in the function of the liver also. And apart from weight loss, there are the different treatment strategies as well as dietary recommendations which can help to prevent the progression of disease. Similarly, if we consider the viral hepatitis, that is hepatitis B, hepatitis C, so whenever there is evidence of chronic infection with hepatitis B or C, these patients should undergo treatment. There are effective antivirals available for hepatitis B as well as hepatitis C, which prevents the progression of the disease from compensated cirrhosis to decompensated cirrhosis, or in patients with chronic hepatitis can even prevent the development of cirrhosis. These the new drugs which have been developed for hepatitis C called directly acting antivirals, they have the efficacy rate of around 90 to 95% depending on the various genotypes for cure of the disease even. Apart from that, there are other diseases also, metabolic diseases, which have like hemochromatosis, as I have said, which is a disorder associated with iron overload in the body. There is a disorder like Wilson's disease, which is a disorder of copper metabolism. So various treatments like phlebotomy or chelating agents, these are available for treatment of these conditions, which can prevent the progress of diseases to cirrhosis and decompensated cirrhosis. So what happens, how do we define decompensation, or when do we say that a cirrhotic patient have progressed from compensated stage to decompensated stage? As I have already mentioned, that in compensated stage of cirrhosis there is no signs or symptoms, or maybe very few subtle signs or symptoms. So decompensation is defined when the patient develops GI bleeding, usually from gastroesophageal varices, which can present as blood vomiting or passage of black tarry stool. Also the development of ascites. Ascites is defined as presence of fluid in the abdominal cavity. Then hepatic encephalopathy. Hepatic encephalopathy is a medical term in which the patients usually develop altered sensorium, irrelevant talk, or the patient may also go into a coma. And the development of jaundice or even liver cancer. Yes, cirrhosis is a pre-malignant condition. So patients in future with cirrhosis may have the possibility of development of cancer even. So this is how decompensation is defined, and then with decompensation the survival is markedly decreased, as well as there is a possibility of a host of complications to develop. There are many complications of cirrhosis. Some of the complications which define decompensation I have already mentioned, but apart from these, some other complications which may involve the liver as well as some extrahepatic organs can develop. Like in patients with advanced cirrhosis, there may be involvement of the kidneys. So it may be because of acute kidney injury, it may be because of hepatorenal syndrome. There may be involvement of the heart. So a term medically called as cirrhotic cardiomyopathy is known. Also there may be involvement of the lungs, as there may be hepatic hydrothorax, which is collection of fluid in the pleural cavity. Then there may be hepatopulmonary syndrome or portopulmonary hypertension. These are all medical terms for complications of cirrhosis where there is defect in the oxygenation of blood in the lungs. So we can see that cirrhosis at advanced stages can involve not only the liver, but there is possibility of involvement of multiple other organs also. And once these other organs are affected, or once the patient goes into multi-organ failure, then the prognosis is very grave for the patient. So that's why it is equally important to have regular follow-up and to take care to delay the progression from compensated to decompensated stage as much as possible. Also, I would like to emphasize on one other important point is infection. See, cirrhotic patients, because of the unusual hemodynamic status, are in a state of immune dysfunction, that is their immunity is low. So when they are prone to develop infections, and these infections can result in marked progression of the liver diseases. Sometimes a term called acute and chronic liver failure develops because of infection in patients with cirrhosis, and this acute and chronic liver failure is associated with a very high short-term mortality in patients. So we need to be very careful regarding infection also in patients with cirrhosis. So I have spoken about what are the causes of cirrhosis, what are the different stages, that is compensated and decompensated cirrhosis. Why is it as important to prevent the progression of disease from compensated to decompensated stages? So now let's talk about diagnosis of cirrhosis. So as I have already mentioned, in early stages of cirrhosis, usually patients may not have any signs or symptoms. So cirrhosis can usually in early stages be suspected on the basis of some blood tests as well as imaging studies. So blood tests like the liver function test we normally do can show that there is alteration of liver function, and imaging studies like ultrasound abdomen, which can show that there is development of cirrhosis in the liver. There are certain features which are defined which can suggest that cirrhosis has developed in the liver on ultrasound. But instead of ultrasound, there are some other investigations which are even more sensitive, and magnetic resonance elastography. All these investigations can be used to diagnose cirrhosis, especially in the early stages where there is minimal signs or symptoms. In advanced stage, usually there is no issue with the diagnosis of cirrhosis because there is development of multiple complications, like I have said, ascites, jaundice, all these things point towards the development of cirrhosis. Next, we come to the management. So what is the management of cirrhosis, or what is the treatment of cirrhosis? So treatment of cirrhosis, one part I have said is already, first part, that is prevent the progression of disease. As such, there are no treatment options available for reversing the fibrosis which has occurred in cirrhosis. But then the question arises that why we treat a patient with cirrhosis? First is to prevent the progression of the disease from compensated to decompensated stage, because in compensated stage the survival is longer, also the quality of life is much better when compared to the decompensated stage. Secondly is the treatment includes the management of complications which are associated with cirrhosis. So for compensated to decompensated state, the progression can be halted depending on the cause of cirrhosis. So as I have already mentioned, the cause, like if it is alcohol, patients should abstain from taking alcohol. If it is associated with non-alcoholic fatty liver disease, then lifestyle interventions, weight loss, sometimes even bariatric surgery helps in preventing the progression of disease as well as resolution of fibrosis. For hepatitis B, hepatitis C, there are treatments available, antiviral drugs available which can be taken to prevent the progression of the disease, and also to prevent even the development of cirrhosis. So next we come to the management of complications. See, each and every complications of the cirrhosis can be managed medically up to a point beyond which the patient has to be considered for liver transplantation. So before the stage at which we refer the patient for liver transplantation, some of the complications can be managed with the help of medicines, diet, as well as physical activity. Now one of the complications which I am going to talk about is ascites, that is fluid in the abdomen. So now we always advise our patients to take a low salt and high protein diet whenever there is development of ascites. This is because in cirrhosis the fluid in the abdominal cavity is responsive to salt. So with more intake of salt, there is more retention of fluid in the abdominal cavity. It is the pathology is in such a way that the more the salt is consumed, the more amount of fluid is retained in the body. And sometimes even if the patient is on medicine but salt intake is not curtailed, then the patient may have no response to the medicines even. Similarly, apart from salt, water intake is also decreased in patients with cirrhosis and ascites, especially those who have a low sodium level as well. in such a setting, actually the sodium level is due to increased amount of fluid in the body. So restriction of water intake helps in control of both the fluid in the abdominal cavity as well as the sodium level. Next, another complication that I want to talk about is bleeding. Now, bleeding is a emergency, and patients with decompensated cirrhosis especially, they can develop potential bleeding from varices, which are dilated venous channels which form in the esophagus, stomach, and also rarely at other locations. Now, whenever there is a bleeding, it's an emergency, and my advice is that the patient should come to the hospital immediately, and there are treatments available, both pharmacologic as well as endoscopic, to control the bleeding. Next, also I will say that this bleeding tendency in cirrhosis, it can happen because of coagulopathy, which is a medical term we use when the coagulation proteins normally which are synthesized in the liver, they are produced less. Now, what is the function of these coagulation proteins? These coagulation proteins, you see, they help in stopping the bleeding normally. You can you know that whenever there is a cut, a small cut or anything, like while working in the kitchen or anywhere, then the bleeding happens for some time and then stops spontaneously. These spontaneous stoppage of the bleeding is because there are multiple proteins at play here, many of which is synthesized by the liver. So when patients have advanced cirrhosis, this synthesis of these proteins are decreased. So these patients have a tendency to develop bleeding. Sometimes patients also develop bleeding interiorly, like in the brain, patients may develop a hemorrhagic stroke. All these things can happen in advanced liver disease, and these are usually associated with very poor prognosis. Also, I would like to emphasize one more thing, that it is not just one particular etiology or cause which can lead to progression of liver disease. Sometimes what happens is patients may have two or more. One example which I would like to give is that hepatitis C and alcohol. So if a patient who has chronic hepatitis C is also consuming alcohol, then the liver disease, its progresses much faster, because alcohol and hepatitis C acts synergistically to damage the liver. So it is very important to take treatment for hepatitis C as well as to abstain from alcohol. So my point is that sometimes it is, what I want to emphasize here is that sometimes it is not just one cause that we have to think about, that liver, if a patient comes with cirrhosis, that only one cause is there. No, there may be multiple problems also. Sometimes alcohol can also be associated with obesity, and a component of non-alcoholic fatty liver diseases can be present. So each and every cause should be assessed and identified. Okay, so what I would like to say is that the liver is a very important organ. It performs a lot of functions on a day-to-day basis, and taking care of the liver is of paramount importance, because when the cirrhosis or advanced cirrhosis develops, there is marked shortening of the lifespan, and quality of life is deteriorated, and there are frequent complications off and on, which are a burden to the patient as well as the patient's family. So I would like to take questions at this moment. One question, which is, what is the main reason for fatty liver? Okay, now fatty liver, there are numerous causes of fatty liver, starting from one of the common causes alcohol, because see, the spectrum of alcohol diseases which I have said is, initially it is fatty liver, then there can be development of alcoholic hepatitis and also alcoholic cirrhosis. Other than alcohol, there are numerous medications or drugs which can cause fatty liver, and nowadays one of the most common causes non-alcoholic fatty liver disease, which is usually associated with obesity, metabolic syndrome, and components of metabolic syndrome like diabetes, dyslipidemia, obesity, diabetes, dyslipidemia, hypertension, and all. So these are one of the few of the main causes of fatty liver, and the most common of which, that is non-alcoholic fatty liver disease, is a disorder of lifestyle. So maintaining a healthy lifestyle is very important if you consider the health of your liver. Okay. Now, another question is that is liver cirrhosis also called cancer? Well, liver cirrhosis is not synonymous with cancer, but I would like to say is that liver cirrhosis is a pre-malignant condition. Now, what is a pre-malignant condition? Well, medically, some of the we say pre-malignant conditions as those conditions which can lead to cancer in future, not cancer but in itself is not cancer. These are called pre-malignant condition. So cirrhosis is a pre-malignant condition, and patients with cirrhosis are at risk to develop cancer, liver cancer, that is medically known as hepatocellular carcinoma. So that's why there is a recommendation that cirrhosis patients should undergo screening with ultrasound every 6 months to identify if there is or there has already been development of liver cancer or not. The purpose of this is that so that if there is development of cancer, it can be detected at an early stage and appropriate treatment undertaken. And next question that I have got is that how do I prevent cirrhosis of liver? Okay, that is a very important question, and to prevent cirrhosis, actually you have to maintain a healthy lifestyle. You have to avoid alcohol. If you are overweight or if you are having obesity, then weight control is very important. Like I said, in patients with NAFLD, 7 to 10% weight loss have been shown in studies to cause significant improvement in liver function. And also, if you are having some doubt about the health of your liver, get it checked. There may be underlying chronic viral infections which initially do not have any symptoms, like chronic hepatitis B, chronic hepatitis C. So if these are present, tests can be done to identify this, and if their treatment is indicated, then with appropriate treatment these viral infections can be kept in control. For hepatitis B, the infections can be checked so that liver damage is not there, and hepatitis C, the new treatment options are available with great chance of cure. Now, drinking or alcohol consumption, how often causes liver disease? See, the thing is, with drinking or alcohol consumption, it is not just how often. See, not all alcoholics develop cirrhosis, but very often you will find that alcoholic patients end up developing cirrhosis. So it is not just taking alcohol once or twice, but for how long duration and how many years you have taken. So the average risk of developing cirrhosis with alcohol can be said to be with 40 grams. Mind it, I am talking about grams, not ml. 40 grams of alcohol for males, and females it is less. Females are even more susceptible to alcohol induced liver injury. So for females it is exactly half, 20 gram per day of alcohol intake. So with continued alcohol abuse of more than 40 gram in males per day or more than 20 gram per day in females, there is chances of development of cirrhosis. So it is not just alcohol consumption, it is also the amount and the frequency, how often you take, that is important. And most commonly, again as I have said, most commonly patients will have fatty liver, which is associated with no signs or symptoms, or maybe very mild signs or symptoms, and like upper abdominal discomfort, and usually the fatty liver, there is resolution with the abstinence from alcohol. So, some patients develop alcoholic hepatitis where there is injury to the liver along with deposition of fat in the tissue, and finally a small subset of patients develop alcoholic cirrhosis. Okay, so it is not that all alcoholic patients develop cirrhosis. Again, if you consider non-alcoholic fatty liver disease also, non-alcoholic fatty liver disease also, it has got two spectrum. One is isolated fatty liver, which is present most commonly, say more than 80% of the patients have isolated fatty liver, and around 20% of the patients have non-alcoholic steatohepatitis. That is a medical term. In simple terms, if I say, it means that there is fat deposition plus there is injury, that is in medical terms inflammation going on in the liver, and these patients with NASH, that is non-alcoholic steatohepatitis, they have the risk of progression to cirrhosis over time. Okay, so one more question is liver transplant a treatment option for liver cirrhosis? Yes, liver transplant is a treatment option for cirrhosis, but it is not just that any patient who has cirrhosis is considered for transplantation. There is stages, there are multiple scoring systems, like one of the scoring system I'll mention is MELD, that is model for end stage liver disease. So these scoring systems that we calculate before considering a patient for liver transplantation. Just because a patient has cirrhosis does not mean that the patient should will need immediately liver transplant. As I have said earlier, that the cirrhosis there are treatment options available which can prevent the progression from compensated cirrhosis to decompensated cirrhosis, and also there are treatment options available which can manage the various complications associated with cirrhosis. But yes, when the disease progresses beyond a certain point, which we can identify with multiple scoring systems available, we can consider such patients for liver transplantation. So if there are no more questions, then I would like to thank you all for your patient listening. Thank you.